Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is produced by Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system, commonly known as Medicare for All. It would cover dental, vision, hearing, prescription, mental health, and long-term care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud, Apple Podcasts, and others so you can listen anytime. And remember, this is an all-volunteer radio station and relies on your ideas and donations to keep us on the air. Before we start today's show, I'd like to take a moment to remind you that on November 3rd, we're going to have what may be the most consequential election in our lifetime. It could very well be that the survival of our democracy is at stake, so be prepared to vote and encourage others to do the same. Once again, Drs. Mike Flynn and Gene Shively join me as co-hosts with their special guest, so let's get started. Dr. Flynn?
Yes, this is Michael Flynn, a retired surgical oncologist from the University of Louisville Department of Surgery. Let me begin with the usual disclaimer, then any comments I make or opinions I express represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired surgeon in Campbellsville, Kentucky. The comments I make do not represent that of Taylor Regional Hospital or Jane Todd Crawford Hospital, nor the University of Louisville Department of Surgery.
Our topic for today are multiple. They're Medicaid issues, reproductive rights, and all of the issues that surround the dysfunctional healthcare system in this country. And we have a very special guest today to help us discuss these issues. But before I introduce her, let me challenge our listeners to double-check our facts. We're going to be talking about a number of issues where there are multiple publications on just about everything. Some of the sources are the New England Journal of Medicine and the Journal of the American Medical Association. They've both had multiple articles on Medicaid issues and reproductive rights, Wikipedia, and you can just get on Google. So our special guest today is Karen Berg. Dr. Berg is a retired assistant professor of radiology at the University of Louisville, and she is a Kentucky Senate representative from the 26th District. So Karen, thank you for coming on today. We're really looking forward to this conversation, especially with your political background. As we have with previous guests, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then the conversation will begin. So, Dr. Berg, Karen, the floor is yours.
Thank you very much for inviting me to be here this morning. This is a subject that is very near and dear to my heart. I am Karen Berg. I'm a retired diagnostic radiologist. I've had experience working both in not-for-profit medical systems like the University of Louisville, private practice. I was a diagnostic radiologist at a small community hospital out in Charlestown for many, many years, where you're responsible for billing and collecting. And then I also have many years of experience at the Veterans, the VA Medical Center, and how we deliver healthcare with the VA. So I have a good background and understanding of healthcare delivery systems. And now I'm an elected Kentucky State Senator. And most of what we are spending our time and energy on up in the legislature at this point does have to do with Medicaid and Medicaid oversight.
All right, Gene, you want to begin the conversation?
I guess, Karen, we're very glad to have you. I appreciate all the work you've done in private practice and the University of Louisville and Jewish and VA. My first question is, what is the big, beautiful bill going to do to Medicaid in this country and to the state of Kentucky?
That's an excellent question. What the Kaiser Family Foundation, KFF, has predicted is that the 2025 federal reconciliation law, which otherwise goes by the one big or the one bad beautiful bill, basically over the course of 10 years takes over $900 billion in healthcare dollars that have historically been paid by the federal government and transfers the responsibility of those costs to the state government, but does it without any alteration in tax structure. So you know how, like right now in Kentucky, our income tax is 3.5%, whereas your federal income tax can be 35%. So what it does is it transfers $900 billion of costs to the states, but it doesn't transfer any of the tax revenue with it. So all of a sudden, you're looking at states that are facing enormous costs that they're in no way prepared to deal with. The estimated 10-year federal Medicaid reduction for Kentucky is somewhere between $17 and $28 billion. So the rough midpoint, we're expecting maybe $22 billion if the bill stays as it is. Those are the anticipated costs to the state of Kentucky over the next 10 years.
Well, that's more than the entire Kentucky budget, isn't it?
Yes, it is. It's way more. We have right now our largest rainy day fund that we've ever had. And that's in the millions. That's not in the billions. We're talking huge chunks of money. I don't know if most people understand Medicaid is predominantly federally funded, depending on which program and which state. The percentage of federal funding versus state funding changes. Kentucky, we are takers. We take more money to supply Medicaid from the federal government than we give. There are other states actually that are what we call makers. They make more money, and so we in Kentucky, being a poorer state, are going to be hurt much harder than some of the wealthier states. And the way it works out, truly, is that the red states are going to get hurt the most, and the blue states are going to fare the best. And that's because the blue states actually are makers. They make money. Red states tend to be takers. They take federal money. Right now, Medicaid can be matched anywhere from 70% federal to 30% state, all the way up to 90% federal and 10% state, depending on the program. But if the state doesn't put up that 10%, then we lose the 90% federal match. So you have to fund it in order to get the federal money. Yeah, it's a complicated system.
Okay. In addition to limiting the access to health care, by the underserved population, there is a significant risk to the rural hospitals that there, for an assortment of reasons, and Gene may want to make a few comments about this as well. In addition to the healthcare issue of a hospital closing, there's an economic consequence to this, because this is often one of the major employers in a state. So,
Yes.
so can you? What are your thoughts? And I would really be interested in knowing what's in the heads of the legislators who live in these rural areas where these hospitals might be closing.
Let me tell you, they understand. Steve Meredith, who chairs Health Services, he's a Republican. He's an CEO of a rural hospital that did close. And he totally understands how important it is to keep our rural hospitals open and solvent. First of all, they provide health care where if they're gone, there is no health care. They are huge economic drivers for their communities. Some of the biggest employers in our rural areas are either your healthcare systems or your public school systems. And without those, the economy fails. I believe the number here in Kentucky right now that we're talking about, we have 11 hospitals, I think, that are at risk of immediate closure, and something like 14 in potential.
I think a bit more than that, actually, around 20, I would say.
Yeah, that may be total.
Yeah. Now let me make a comment that I've made on this program before, and then ask you to respond to it. Now, 20 years ago, there was a general surgeon in Louisville, and you may remember him, I'm not going to mention his name, who had some visual issues. He retired and ran for office and became a member of the House of Representatives.
Dr. DeWeese.
Yes. Okay.
Yeah.
Well, he gave a talk at the Louisville Surgical Society, and this is 20 years ago. And he made two very strong points. Number one, what we've all heard many times before, that making laws is like making sausage. And one of the examples he gave is that he had proposed, I can't remember what it was, a bill or something, and by the time it had gone through all the committee system and everything else like that, he voted against it.
Right, he couldn't, yeah.
And the other thing he said, and he was very, very, very clear about this, is that the politicians, the legislators, do not understand health care. They run, they're accountants, they're lawyers, they run road services and grocery stores and lumber companies, and they simply do not understand health care. Now, so my question to you now, is that still true, or are some of them recognizing some of the issues? It sounds like that it's getting a little bit better than it was then.
I think it's getting a little bit better than it was back then, in part because I'm not the only healthcare provider that's up there at this point. We have several other electeds with deep experience in the healthcare system, but even more importantly, it is becoming such a large percentage of our state budget that you have to become knowledgeable. If you are not knowledgeable about these delivery services and different options, then you're going to make big, bad mistakes, both in your budgeting and in your legislating. So, I think there's more knowledge. There is still definitely a limit to the understanding of healthcare delivery systems, how payers are paid, how hospitals stay open, how patients, there's this overwhelming thought process in Frankfurt that it's the patients that are doing the fraud in Medicaid. It's like the problem is that people are signed up for Medicaid who don't deserve it. And that's what they think the fraud is. That has nothing to do with anything to do with the significant financial fraud that Medicaid deals with, which comes from providers. It does not come from patients. It comes from people billing intentionally systems that they know they shouldn't be getting paid for, but doing it anyhow and taking the money. So the whole work about getting people off of Medicaid that don't belong on Medicaid, it's ass backwards. I'm sorry, but it is not under any circumstances going to solve the problems that we are facing as a country. It is a waste of money because it's going to cost us a lot of money to implement these systems where people have to reapply every 6 months, and they have to show that they've worked so many hours, and they have to show that that for somehow they are human enough that they deserve this.
We've done 2 programs on this single payer radio with Dr. Barbara Casper. You may remember her as an internist at U of L, and a lady named Amber, who was a Medicaid recipient who didn't want her last name mentioned. And then one of the things I learned from her was some of the administrative hassles of having to establish eligibility, work requirements, and this stuff that really it really doesn't have it represents a fraction of all the people who the children, the elderly, the disabled, who are eligible for that. Now, do the politicians have any understanding of that?
I don't know. I mean, these are some basic numbers for Kentucky. Okay, for Kentucky.
Yeah.
50% of our children are covered by Medicaid.
Yes.
1 out of every 2 children. 70% of our nursing home residents are covered by Medicaid. Medicaid also covers severely disabled people to help them either stay at home and out of institutions, or just to help them with the cost of their medical expenses. There is a group called the Expansion Group, and it's the Expansion Group that my Republican legislators are trying to target, even though honestly they're targeting everybody, because we just had a whole fiasco with whether or not the Lee Specialty Clinic could stay open or not.
Yeah.
And, that's not targeting expansion population, guys. That's targeting the most needy of our population. So with these expansion people, okay, in order to be eligible for expansion Medicaid, you have to be 138% of the poverty level, which is not much money. A family of 4 making $44,367 is the top limit for the expansion population. A family of 4 living on $44,000 a year. Okay? Now, what this whole big bill is doing is trying to get people in that expansion population off of Medicaid by making the requirements so onerous that people can't meet them, that you have to re-verify every 6 months. And guys, that costs the state money to implement, because we have to have employees to do this for them, that you have to show that you've been working for 3 months prior to eligibility, even though the federal guidelines right now say 1 month, but Kentucky, because we want to get these people off, decided, no, we're going to go with 3 months. thing is, it is more. There's so many arguments here. These are, for the most part, people that work. Almost somewhere between 70 and 90%.
Now, you're talking
of the
about
expansion
Medicaid recipients.
Medicaid recipients
Yes.
in the expansion population, the vast majority of these people work. But they work at jobs that, one, do not offer health care, or two, offer health care, but it is so expensive that their employees who are earning minimum wage can't afford it. And we have found out, and this just blows my mind, honestly, that some of the biggest employers in this country do that intentionally. Intentionally offer health care that they know is above their employees' ability to purchase.
That's exactly what we learned from Amber, and they put them on some sort of instead of a full-time employee, they're working as part-time or
Right, they put them down to 32 hours a week, and you're not
Yes,
eligible,
yeah,
or
so
36, and you're not eligible.
And these are companies that are making billions of
Billions
a
of
year.
dollars, and then by doing
Yes.
that, they no longer have any responsibility to put in their percentage of costs for their employees, for their health care. They're just sending them to the market. So that the government is subsidizing these employers, making tremendous profits using taxpayer money
Exactly.
to do
Yes,
it.
yes.
Exactly.
And it has got to be stopped.
You know, I'm fond of saying that Walmart's healthcare benefits that they offer to their employees are counseling on how to get on Medicaid.
Right.
Well, that's
right.
one of the examples that Amber that made
Yeah.
on two of the programs that she was
And this
on.
is, I mean, guys, this expansion population, they are not lazy. They are not people that are trying to get something they don't deserve. For the most part, these people are either working and cannot get covered through their jobs. And remember, guys, this includes self-employed people. People who want to have their own business. Again, they don't have options for private insurance that people can afford. And then you have to understand, with the private insurance market, the premiums on average now, I think, are $26,000 a year.
Oh, wow.
Yeah.
But the copays and deductibles, particularly the deductibles, if you have a policy with a $7,000, $8,000, $9,000 annual deductible, nobody can do that. You get sick in October, you've got $9,000, and then all of a sudden in January, another $9,000. This is not doable for the vast majority of people in the United States. So we have problems on the private health care industry, which is still making tremendous profits. But we have so many people that can't access it. And then,
Let me point out that there are also people who are working in the medical industry, hospitals and assisted living, and who are on Medicaid because they make minimum wage, and so they don't have enough of income to pay for the insurance.
yep.
Well, listen. Not that I want to stop this. I think it's really important, but I'd like to ask you to, just to get some other issues on the table. Our listeners are not mostly medical people. So could you kind of explain the details of the Kentucky state anti-abortion laws so that our listeners can understand? I mean, the consequences of that make it incredibly difficult for obstetricians and gynecologists to treat a woman with the complications of pregnancy. And I personally am a little confused about, I mean, the way they're written, it's so vague and confusing. it's hard to know what to do.
It's very difficult.
Yes.
Very, very difficult. What Kentucky did, we passed this trigger ban, which meant that as soon as Roe fell, we lost access to abortion in the state of Kentucky, with very, very few exceptions. There is an exception for ectopic pregnancies and an exception for miscarriages so that you can go back and do a D&C afterwards. And then we have an exception for the life of the mother, or it's not her health, but preserving an organ. So, and that's it.
Now, it was my understanding that if a woman is, say, 8 or 10 weeks pregnant and has a miscarriage and ruptures her membranes, and the ultrasound shows a little flicker
Right.
that is going to be a heart if it lives long enough.
But it's not going to, because the membranes are ruptured.
Is still flickering. They can't do the appropriate treatment
No.
for that woman.
Right.
Well, I mean,
No, and we've had cases in the state literally where women are bleeding effusively,
yes.
and doctors felt that they had to wait until there was no longer, they call it cardiac activity. It's not cardiac activity. It's not even a 4-chamber heart at that
That's
point.
right. It's a flicker.
It's
yes.
a little flick of emotion.
Yes.
And we have to wait for that to be gone in order to take mom to the OR. Or the other option, we can wait until mom is so unstable from her blood loss, then we can take her. It's craziness. It is not medicine.
No, it's malpractice.
It's malpractice. It is.
What
I agree.
about
Gene,
what about ruptured membranes in the second trimester? How does that?
You know
how's
what they want you to do? Honestly, I've had this in committee. They have said she can just walk around with that dead fetus in utero until it's spontaneously excavate. But the problem is you get septic and you get
Yes.
disseminated intravascular coagulopathies, and we don't take patients to the brink of death intentionally in an effort to try to bring them back. We try to prevent what we know is going to happen if we don't intercede. This is real. This is
yeah.
real.
Another issue, in my understanding, again, which is limited, is if you have a fetal anomaly, like an anencephalic fetus. That's a fetus for our listeners to understand that doesn't have a brain.
No brain, no head.
So if this goes to term, it dies. It doesn't live very long. And to force a woman to carry an anencephalic fetus to birth,
It's cruel.
It's cruelty.
It's
yes.
cruel. I mean, first of all, you have all the complications of pregnancy and childbirth with none, it's everything in medicine is a risk benefit analysis. You're taking all the risks with no benefit. The fetus is dead. Why would you want to take those risks? On the other hand, mom can have that fetus, dead fetus, removed from her uterus. She can heal, and she can go home and get pregnant again.
Yes.
That's what we want. We want these women to survive and be able to produce.
That brings me back again to that question about the politicians understanding health care, because the anti-abortion legislation in Kentucky is so far off the mark that at least in my opinion, as well as I can understand it, and I'm limited because I'm not an obstetrician or a gynecologist, it requires the physician dealing with the complications of pregnancy to commit medical malpractice. It's just,
Karen, is it not possible we could change these few things and get proper treatment for complication of pregnancy? Will the legislatures not even listen to that?
Some would and some will not. It really depends on who you are and what your background is. I will tell you that the legislator who brought the overall maternal bill that we passed several years ago, Nancy Tate, is not coming back. She has opted not to run for re-election. So in her absence, we may have some room to move. But I'll be honest, right to life in this state is extremely strong and extremely close, very close to some of our more powerful electeds in the state. And I could go into names if you wanted me to, but I don't know if I should.
I guess I have to throw out this warning. I mean, we are non-political.
Right.
And
So I won't use names. But you have to understand, guys, we have politicians elected, even from Jefferson County, who are in bed with these right-to-life physicians, or these right-to-life lobbyists. And they take a lot of money for them, and they do their bidding.
What
That's
about the
truth.
right to life for the mother?
Right. What about the right to life for the mother? What about the truth is, my religion, I'm Jewish. The truth is my religion requires that you, if you have to choose, you choose the mother over the fetus. According to Jewish law, that is what you're supposed to do. And our laws in Kentucky prohibit that at this point.
well, let me pop something else onto the table while we're doing this, because we may talk about this some more. I think private equity companies in medicine now are involved in, you mentioned 70% of Medicaid recipients are in nursing homes. Well, it's my understanding that almost 70% of nursing homes are run by, and isn't that what you told me, Gene? I think.
Yes, that's correct.
Yes.
And it's more than that in South Central Kentucky.
Wow.
Every nursing home in my county and surrounding counties is owned by private equity.
Yeah.
The interesting thing is that they don't tell anybody.
Well, of course, but they run physician practices.
Mm-hmm.
They run the hospitals. So they run hospital systems. There was a hospital system in Boston that collapsed because it was run by a private equity company that basically sold the building that the hospital was in, and then had the medical company have to pay rent to be in their building. And then when it collapsed, the CEO of the private equity company turned some of these things into to condominiums. Anyhow, can you share some of your thoughts? And again,
I think private equity.
And I'm going to ask you again did your fellow politicians understand?
I think they do.
The implications of having a private equity company running a healthcare system.
I think that the ones that are paying attention do understand that this is a very bad thing that is happening in medicine. I mean, what these private equity companies, what they think is that they can buy practices, they can buy hospitals, they can buy outpatient centers and make money off of them, where the previous people, like the physicians that had run these centers, couldn't. They think they're smarter, they know how to handle things better. Basically, though, what they do is they go in there, they figure out what makes a profit for us and what doesn't. It has nothing to do with the needs of the population, nothing to do with the needs of the patients, nothing, honestly, to do with quality of care. The bottom line is, are we going to make money? And study after study after study after study has shown that the quality of healthcare delivery goes down in practices that are bought by private equity over and over and over again. I personally think we should outlaw it. I do not think that you should buy medical practices with the goal of doing nothing but making a profit. That is unethical and immoral, and that is happening in this country day in and day out. I think my fellow legislators understand it. They don't know how to stop it.
Dr. Berg, the Medicare for All movement across this country, the battle cry is patients over profits.
Yes.
It's everywhere across this country.
Yes.
Right. And the goal, the first goal is do no harm. But the second goal is to take care of people, to actually provide health care, not to make a profit off of people's illnesses.
Let me give you an example. I can give 2 or 3 of them, but there was a nursing home in Florida that was owned by a private equity company. And there was a woman down there who had a decubitus ulcer. And for our listeners, this was an ulcer on the lower part of her back. And she got it because she was lying in bed all the time and not being moved. They didn't change the diaper enough, so it got infected by fecal contamination. For our listeners, that's poop. And she died. And the family, understandably being angry, were hired a lawyer. And they ran into this complex of administrative nightmare. One company owned the building. One company had the nursing home license. One company provided the professional staff. One company provided the custodial staff. And there was nobody took, there was no responsibility for what happened to
Who
that
provided
person.
the medical oversight?
Yes, exactly.
Accountability, that is
The
a big
accountability
issue.
and
And there are,
and the care.
Yes.
The actual care of that person.
Mike, that's going on right here in South Central Kentucky.
I know, Gene. Go ahead.
And there's another nursing home that had local physicians that were taking care of patients, and most of the physicians and the patients knew each other. The same way with the nurse practitioners that were involved. And those people all disappeared, and they brought in physicians and nurse practitioners from out of town, which none of the patients or family knew. Now that creates a real problem with continuity of care and trust between patient and physician and nurse practitioner. This is it's becoming a really huge problem that we have to address. Karen, what about pharmacy benefit managers?
Why are we laughing?
Because PBMs, honestly, are the newest leech on healthcare. I mean, an absolute freaking leech on healthcare dollars. They insinuated themselves in between patients and their doctors, and they have now decided, based on their profits, not efficacy, not how well a patient responds, based on profit margins, which medicines they will allow to be prescribed and which ones they will not. And guys, it's all on kickbacks. they're getting kickbacks from the pharmaceutical companies to make these decisions. You know, we used to, when we first came up with hospital formularies, it was based on how well the drug worked versus the cost of the drug. That was what we really cared about. None of that matters anymore. None of that matters anymore. It is all how much money they can get.
And there's a very fundamental reason for all this. We do not have a healthcare system in this country.
They're not regulated.
We have a healthcare industry, which is focused, and whether it's the 900 for-profit health insurance companies, the pharmacy benefit managers, the fact that Medicare, and I still think that's true, cannot negotiate with the drug companies. You know, there's a couple of things.
10 of them now, I think. I think it's 10, yeah.
Yeah. I mean, it's astonishing that this goes on. And again, I'm going to go back to you with the politicians not understanding this, or are they getting so much money in contributions and donations from this company that they don't care?
The truth is, the problem with PBMs is multifaceted. It needs to be dealt with federal legislation. But our Congress is incapable of passing legislation of this caliber at this point. You know, our current Congress, I'm talking about the House of Representatives in D.C., not in Frankfurt. This Congress has passed fewer bills than any Congress, any sitting Congress ever in the history of the United States of America. They are completely dysfunctional. They have all sorts of bills written, the PBM bill being one of them, that they cannot get done. We've tried on state level. States are trying to manage pharmacy benefit managers, but it's tough. It's tough. I wrote a bill last session about step therapy. Are you familiar with step therapy? It's where the insurance company, your doctor writes a prescription, and the insurance company can say, no, that's too expensive of a prescription. We want you to try this first, fail it, and then we'll give you the more expensive prescription. Like the doctor doesn't, or the healthcare provider doesn't actually know what they want and don't actually have a reason for prescribing this over this. So I just wrote a bill that says they're not allowed to do that without getting the provider's input first. The provider gets to explain to them why step therapy is not appropriate, as opposed to right now where they just do not fill the prescription. And I think we got it passed. They passed it in Illinois last year. We think we might be able to get it in Kentucky this year, and if we can go national on that.
Yes,
but these are just middlemen who have just decided that they can make more money by not providing what the healthcare providers want for their patients. It's just another way for them to do it.
Yeah, this term is called vertical integration.
Mm-hmm.
And CVS right now is the superstar of vertical integration.
Yep.
Well, United Healthcare is pretty close to CVS.
Yeah, and I honestly think we should break up vertical integration. I don't think you should be able to say that you have to use our pharmacies, you have to use our hospitals.
It's for the audience. CVS owns a health insurance company. They own some doctors. They own a pharmacy benefit manager, and they own a company called Signify Health, and they're all vertically integrated.
Well, that's healthcare in this country. I mean, how many people are in private practice by themselves that don't work for a hospital or a hospital system or some other organization like that? It's awful.
You can't do it. I just in the last few months, right here in Campbellsville, I know one, two, three or four doctors and multiple nurse practitioners who had to get out of private practice. They couldn't do it. It's impossible to do.
It's very difficult at this point.
Well,
Very difficult.
let's we'll change again horses in midstream here to a kind of a different approach. This is a program sponsored by Kentuckians for Single Payer, promoting Medicare for All, which we all are here. We're not getting paid. The prospect of this becoming a reality in this political climate, at least to me, doesn't look very good. And so my question to you is, what suggestions do you have that could improve the recognition of the benefit or the value of this non-profit government-run health insurance program by both the public and your co-politicians?
Yeah. That's a big question.
I know it is.
Yeah, I mean that's a
minutes.
really big question. I could ask you to break it down into component
Well,
pieces, but
let you do it whatever way you're comfortable.
I think it is well established that our healthcare delivery system in the United States is broken. For most people, the cost of premiums and the cost of their deductibles, these are, people with private pay insurance. It's getting out of control. For the younger people, they honestly think it's a joke. You mean I'm going to make this much money and then I have to pay this much for my health insurance, and I only get to use it if I'm sick? I mean, they're thinking I'm just not going to have health insurance. And what happens then, the whole healthcare delivery system falls apart because it costs money to run hospitals. It costs money to train doctors. It costs money to have nurses and equipment. And if there is nobody to pay, nobody who can pay for that, then the whole thing collapses. And private insurance is not an option now for a large percentage of people in this country. That entire Medicaid expansion population, which isn't that big, I think it's like 7.6 million people, I think. Don't quote me on that. That's off the top of my head. They will be uninsured. It's not that, they're going to be able to switch to a private insurance. They're not. First of all, people have been terrified their entire lives because they have been told by the insurance industry that private health insurance is the only way to go. And if we do anything other than a completely capitalistic healthcare market, they will lose all the advantages that they have as Americans with the best healthcare system in the world. First of all, it's not the best healthcare system in the world. It's far from the best healthcare system in the world as far as our outcomes. And for what we spend versus our outcomes, we are not competitive with other major countries at all. So the whole cost of the private healthcare market, which is a for-profit business, is actually keeping people from getting covered. And then you go to the public side, and you have options that are more affordable only if you're going to subsidize them. And then you have legislators who say, why should I subsidize this? Let them go and buy health insurance just like I do. But it's not the answer because it's not feasible. They can't do it.
Well, again, I've asked Gene this question multiple times, is what is in the heads of the people in red rural Kentucky that keeps putting the legislatures into office.
Let me tell you,
who pass bills that are against their economic and health interest. Gene, you want to make a comment about that before we let Karen respond to my comment? Gene, are you there?
Yeah, yes, I do. Well, I don't think, I think it's like having cancer. You don't really think about it. You don't know much about it until you get it. And then it may be too late. Hopefully it's not. But most people are not really thinking about that. And I think there are other issues that are affecting their votes other than just plain economics. But that may be changing. Some of the inflation we're having, some of the costs for farmers. But the main issues are, I think, in rural Kentucky are abortion, big government, somebody telling you what to do, somebody telling you that you can't go to church because there's an epidemic going on, just like what happened this morning in the Senate, condemning Dr. Fauci. Those kind of things are affect people more than direct health care. I think there may be some gradual change. It's just like the conversations we've had with Don Henderson in the past. He says he doesn't think anything will happen until there's a crisis, and that crisis may really be a crisis that will take us a long time and a lot of pain and suffering to get over.
Karen, your thoughts about this?
I just want to say, though, I think, Gene, you left out a big one here for Kentucky, and it's the big elephant that we call racism.
Well, I can tell you, I was born and raised in Taylor County. When I was a kid, there were bathrooms for colored and white. The schools were segregated. I can tell you, coming back here and living here, when I got through my residency, that is radically changing. It's radically changed, and I don't see much racism here in Taylor County and the surrounding counties.
I have to agree with you on that, but I will say that I run into occasions all the time out in public where I see it. It's kind of, I call it covert racism or latent racism that's a vestige of what you said you went through when you were growing up. I think it's still here, and I think it's a problem for our society.
Well, if it is, it's very, very suppressed because at the hospital we have several Afro-Americans, nurses and doctors, and over the 46 years I've worked at Taylor Regional Hospital, I have never, ever seen a problem. I'm not saying that there could have been problems that I don't know about, but it just blows my mind how different it is. There's interracial marriage, and there's people socialize together. It is really, really different.
Well, now let's get back. My question was, how do we get a recognition into the brains of the rural voters and the politicians about our dysfunctional healthcare system and the benefits of having a not-for-profit, government-run health insurance system?
Well, the first thing I think we should do is we have to change the government in Washington.
Well, yes, and in Frankfurt as well.
Yeah. Right, but I don't think we have to concentrate on that right now. There's no possible way we can change it right this minute. But if we change that and change Congress, in November, we may be able to start working on it.
Now, one of the reasons that I do this program, because I'm not getting paid for this, and it's a lot of work getting people set up to come and do these things, come down here, is the hope that the information and the things that we talk about here will penetrate some of the brains of listeners. And I get this report from you every month, Gene, about who's listening to these programs, and apparently they're getting around to a lot of different places. So, hopefully somebody's listening, and hopefully they're understanding.
Actually, I only get the report on one of the podcasts. There are multiple other ones that I don't have the numbers on. But I think that we can gradually make progress, but we not until we change the government right now. And that's why I tried to emphasize that point last night in our meeting, that we have to select who can win and get those people in office, and then start working on this.
Okay, guys, we've got about 2 more minutes to go. So.
Wow. Karen, you want to make any last-minute comments, and then we'll let Paul take us out.
Every human being deserves access to good quality health care. And in the United States, being really probably one of the wealthiest countries in the world, we don't seem to have conquered that. We actually are doing a much worse job than other countries that are much less affluent than we are. And we spend a ton of money on healthcare without getting the results that other countries get. So we have to rethink what we're doing. We have to really allow people to open their minds, get over the fear that they intentionally put into you growing up, that anything other than a private, for-profit healthcare network would take something away from you. And they made that over and over and over again clear to everybody in this country through their advertisings and their campaign. Everybody thought, if we lose our private health insurance, we are going to lose our quality health care. And it is not true. We can have better health care for less money and cover more people if we just rethink our healthcare distribution system.
Thank you very much, Karen, for those remarks, and thank you very much for coming on here today to do this program.
I'd like to thank my co-hosts and Dr. Karen Berg for making today's show possible, and a special thanks to our listeners for tuning in. For more information on today's topic, go to our website at kyhealthcare.org. And don't forget, with a little more than 80 days to the November 3rd election, let's all start getting fired up to go cast our vote. This is Paul Hoppy wishing you a wonderful rest of your day.